So this is the GYN Pathology Journal Club for July 2020. The theme is ovarian germ cell tumors, and my name is Natalie Benet. The GYN Pathology Journal Club, as a brief explainer, was started last fall for the fellows at my institution, and in the era of COVID, it was moved online. We have been doing this online since April, so this is our 4th online Journal Club, and today's theme, as I mentioned, is germ cell tumors of the ovary, but each month there's a new topic and it rotates every 12 months back to the topic we've already done before, obviously with different articles. Today's learning objectives are to increase the knowledge about germ cell tumors of the ovary, including new research methods and practical applications of those methods, and to enhance the ability of the participants to critically evaluate literature. This month's articles are 3, which we will go in this order as long as the presenters are all game for that, and they're listed here. This month's presenters are 3 very accomplished trainees. Dr. Fouad Zakka is a PGY4 at my institution, and I've worked with him before. Dr. Veronica Ullici is also a resident at Brown. She's a PGY3. And she is currently rotating at Women and Infants Hospital. And then Dr. Sameera Rashid is a current GYN and breast fellow in Cotter. And she has presented before, and I'm looking forward to hearing from her again. And so I just wanted to quickly plug, if anyone on the call would like to present or knows someone who would, the next month's theme is vulva and vagina. You can contact me at the email from the newsletter. I will give you a template and go over the presentation with you before you participate if you are new, and you will make 2 questions for the follow-up quiz, and you will hopefully gain some knowledge about presenting and about the literature. Another plug is for the International Society for GYN Pathology. You can join this if you're a trainee for free, as long as you know someone who is in the society who can basically vouch for you. They have an associated journal, they have conferences at national meetings, and I know they're launching some teaching opportunities, which will be virtual, and you can contact me if you'd like to do that. And they've recently actually partnered with the International GYN Cancer Society, which does virtual tumor boards, has publication opportunities, and their virtual tumor boards are all over the world, pretty much every continent you can imagine. So this is a brief overview of germ cell tumors of the ovary according to the WHO 2014 classification. Today we'll mostly talk about mature and immature teratomas. I highlighted in gray the yolk sac tumor because that does come up, and I should have highlighted embryonal as well as a component of a sort of mixed germ cell tumor in some of the papers. And I just briefly wanted to touch on grading of immature teratomas. The grading system, which you can see here in this table, grade 1, 2, and 3, has been traditionally used, and it was adopted or adapted from this 1976 paper from these authors here. They had 58 cases, and they adopted this grading criteria. And basically, we all, or some of us know that you're looking for immature neuroepithelial tissue and how many low-powered fields or 40x fields those occupy in the tumor. So a lot of folks have advocated for low and high grade classification, so kind of clumping grade 1s together and then 2 and 3 as sort of non-low grade, or just call them all high grade, but some people still use grades 1, 2, and 3. So now we will go to our presentation. So I will stop sharing my screen, and Dr. Rashid, if you would like to go first.
Yeah, sure. I'm Sameera Rashid. I'm Breast and Gynae Pathology Fellow at Hamad General Hospital, Qatar. Qatar is a small country of 2.8 million population, but we have people from more than 94 different countries. So that's what got me interested in this paper, that is Global Incidence Comparisons and Trends in Ovarian Germ Cell Tumors by Geographic Region in Girls, Adolescents, and Young Women from 1988 to 2012. This is from Gynecologic Oncology, September 2019. It's by Dr. Hubbard and Poynter from University of Minnesota. Just a brief overview of the germ cell tumors. Looks like some of the images aren't showing. Yeah, this is the one. just a brief overview of germ cell tumors. These are the ovarian tumors derived from primitive germ cells of the embryonic gonads, and they comprise 15 to 20% of all ovarian neoplasms. Here I have the ovarian counterpart of testicular seminoma, which is the dysgerminoma. This is a yolk sac tumor with the pretty sheer dual body, and here is embryonic carcinoma with a lot of atypia, necrosis, and hemorrhage. Then choriocarcinoma with syncytiotrophoblasts, cytotrophoblast, and one of the most common ones, the teratoma. So the incidence patterns and trends differ between gonadal and extragonadal germ cell tumors, suggesting the etiology may differ. The frequency of germ cell tumors relative to other histologic subtypes of ovarian cancer differ widely in children and adults. In children, the germ cell tumors represent 75% of malignant ovarian tumors, while in adults, they only represent 5%. So the aim of this series is to make a comparable data available in as many geographic locations as possible by providing peer-reviewed data from population-based cancer registries worldwide. And basically, the goal is to understand whether genetic or environmental factors were more likely driving geographic differences in incidence. And for this study, data was extracted from cancer incidence in 5 continents and CR13 registries from 1988 to 2012. The rate of ovarian germ cell tumor in women and girls were calculated in 4 different categories, that is 0 to 9, 10 to 19, 20 to 39 years old, and standardized to the 2000 and 2025 average world population. Data was aggregated within subregions corresponding to the United Nations Statistic Division GeoScheme, and then incidence rate was presented as incidence per million and compared in subregions, and average annual percent change was estimated using Poisson regression. So just I'll go through the result that they got in different categories. The first one is 0 to 9-year-old. This is the category with the lowest incidence as compared to the other groups, and within this category, the highest incidence was in the Eastern Asia and the lowest was in the Oceania. In the United States, the incidence was highest in Asian Pacific Islander. 10 to 19 years old, this is the second category and the one with the highest incidence. And in this category, geographically, the highest incidence was in the Eastern Asia, followed by Western Europe and Oceania, which included New Zealand and Australia. And within the United States, the highest incidence was in Hispanic population, followed by Asian Pacific Islanders. Also in the high and very high Human Development Index categories, they noticed an increase in incidence of 1.79 and 2.06%. The third category is 20 to 39-year-olds, and for this I'll take you to a very nice graph that they have included in the paper. So just for the sake of comparison, this is the incidence in 0 to 9-year-old. Then 10 to 19-year-olds, it's a higher incidence. The incidence in 20 to 39-year-old, it's lesser than 10 to 19-year-olds, but still it's high incidence. In this, the highest is in the Central America, but if we compare that, Eastern Asia is quite similar. But in both the categories, Sub-Saharan Africa has one of the lowest incidence. These graphs or plots, they show the incidence inside the United States. And in all the 3 categories, the incidence is highest in Asian Pacific Islanders. And here it's lowest in the Hispanic and the non-Hispanic whites. So those were the results from the study. A few points that I liked from the discussion of this paper is that the pediatric germ cell tumors overall, risk factors that have been evaluated include parental demographic characteristics, in utero exposure to hormones and pesticides, maternal reproductive history, and many more. However, none of them has emerged as a consistent risk factor. The only few risk factors that have been evaluated specifically in ovarian germ cell tumor include inflammatory cytokines during pregnancy and maternal hormone exposure. Going towards the strengths and the areas of improvement for this study, first of all, the basic idea or the goal of the study was to establish the global incidence. And I think it achieves that goal. Second, the incidence per million, they mention, and the graphs and plots, they were very easy to follow and understand. Third, they limited the study to ovarian germ cell tumors. It made the comparison easy on one hand. Also, since this study aims to provide a foundation for more studies to come, so I think this was a very smart choice on part of the epidemiologists. And last was that they mentioned their limitation themselves. So I'll go to the limitations of the study. First of all, the disproportionate regions. That is the sub-Saharan Africa, which is a huge region, versus Central America, which includes just one country, that is Costa Rica. Then was lack of data in some regions. And these regions were the low human development index regions. So the high and very high human development index countries were overrepresented in this data. Also, being a pathology fellow myself, so I felt like there was, I would have liked to see a comment on the different types or stage, or at least the different risk factors that we see in different regions of the world. But I guess it would be unfair to point that out here. But overall, the take-home message from this study was that the incidence rate was generally higher in Eastern Asia, and the concordance of international rates with ethnicities, that we saw that outside the US, the incidence is highest in Eastern Asia and inside the Asian Pacific Islanders. So there could be a genetic etiology. Also, there was limited data in low and medium income countries. The analysis stratified by Human Development Index showed precise but small increase in incidence in high and very high Human Development Index categories. Now, this could be because of the change in reporting, surveillance, diagnostics, and healthcare delivery over time. But overall, I thought it was a good study.
I agree. I think that was a really good presentation. And I like to present clinical articles because I think it's important as a pathologist to, familiarize ourselves with these trends. And you can stop sharing now if you want, Dr. Rashid. I think that was really well done. Does anyone from the group have any questions for Dr. Rashid? Or maybe you typed them to me. I don't think so. Okay, I have one. I think you mentioned that there's perhaps a role for study into genetics. I find it interesting, and I don't know if this is really a question or more of something for you to comment on, but I was thinking about things that like gastric cancer, they're common in certain parts of the world. And then when those folks move, right, like they move, like the example I'm thinking of is like, people from say Japan or something, and then they move to the United States and their risk of gastric cancer sort of normalizes to that of the United States, but then their risk of something that's more common here, like colon cancer, right, goes up. So I find it very interesting that these tumors, that doesn't really seem to be happening, right? It seems like this Asian and Pacific Islanders here in the States even are showing an increased risk, as are the folks in East Asia. So yeah. And are these tumors that you're seeing a lot where you are?
I've only worked in Qatar, so I don't know how to compare, but yeah, we see a lot of
germ cell tumors.
Germ cell tumors a lot.
That's good, because I don't see them terribly often. They're not that common, but I always when I'm trying to go to the frozen room with a resident or something, I'm always saying, like, make sure it's not just for pathology boards, but when you're thinking about how old is this patient, what's my differential diagnosis? And there are certain age groups like this, 19 to sort of 25, where anything or, anything is possible. They can have epithelial, they can have germ cell, they can have second stromal. So it's a good paper and it's a good thing to keep in your head. And for those who are studying for boards, this is the kind of stuff they like to ask you. Oh, Jonathan, did you raise your hand? Did you mean to do that? No, you're muted. Dr. Wawire, I see your blue hand is raised, but I don't know what that means. Okay. All right.
Wait, I was...
Oh. Did you have a question? Go ahead.
I finally got around to unmuting myself.
Okay.
Hi, Dr. Bonet. Hi, everyone.
Good to see you. I hear you.
Jonathan.
Hi, everyone. So, Dr. Rashid, thanks so much for that very nice presentation. And it kind of gives a landscape of how germ cell tumors of the ovary, are distributed across different parts of the world. Yes. The only problem with that kind of study, especially when it comes to regions like what they call sub-Saharan Africa,
right,
is that it's always limited by data. They don't have enough data.
right.
And
They don't. Yeah, they don't.
Yeah.
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 And the second problem being that sub-Saharan Africa isn't really a region as such, because there's really no rationale for calling a region sub-Saharan Africa, the region sub-Saharan Africa as they do. So it doesn't really represent anything other than more of a socio-political classification than a regional or ethnic classification like Southeast Asia. And I might even be wrong on that.
Yeah.
So, and to address the first problem, what I think should happen, because one of the big reasons why we don't have much data from this region is that most of it is not published. And most journals, even at a stage like now, wouldn't publish a paper that just describes the incidence or the prevalence of a certain type of germ cell tumor.
I see what you're saying. So it's
most,
like,
most
not
journals are like,
right.
Yeah, exactly. And
Yeah.
for that reason, it almost feeds into itself such that people don't publish because journals won't publish. So to some degree, if you were to go looking for data on these tumors, even in a country like where I am, where we have a bit of a, some degree of a registry, it doesn't go to that point where you can actually say ovarian cancer, serous is this, germ cell is this,
Right.
but this is that it's not possible.
Yeah. Well, Jonathan, I think what we need to do is have you connect with the cancer incidence in 5 continents folks, because that's where they got their data from. And I was reading about it, and it's actually a pretty exciting thing. So I think, you can change the world. I agree. And the other thing that I thought was interesting is when they're talking about the data, I think for all of Latin America comes from Costa Rica. Like that's it.
Yeah.
It's the only country that they can get data from. So definitely some shortfalls here, but it's interesting even with those shortfalls to see that trends emerge, right? And that we can try to do better. But yeah, thanks for the comments. Yeah, did anyone else have a question for?
Yeah, I have a question. I don't know if it was mentioned, but the incidence highest in East Asia. So what kind of countries in the East Asia? Because it's like, for example, stomach cancer is high in Japan and South Korea, but not as high in China. So I just wonder, because I'm from South Korea, but I'm not practicing there or trained there, but just out of curiosity, if they broke down the Eastern Asian countries in different
They did. They
parts.
have this. I'm trying to figure out how to share my screen. There we go. So they have this picture. Can you see it now? Gahi, I assume that's you. It sounds like you.
Yes, I can see. Yeah, that's me.
Yeah. So they have these, and they're defined by this data set, and this is how they define East Asia. So I don't know if they actually go through and write the countries out, but this is a well-defined sort of criteria of countries. So I could look that up and get back to you. Dr. Rashid, do you happen to know that off the top of your head? I wouldn't expect you to, but.
No, I'll have to check.
Yeah, that's fine. It's a good question though, because it is interesting how, sometimes these categories are written, and then even the people who live within the categories, like, Dr. Well, we were saying, well, wait a minute, hang on, that doesn't really make sense. So I think these kinds of things are constantly being revised, which is good. So now we'll move on to the second presenter. So I will stop sharing, and I believe it's you, Dr. Ullici. Would you like to?
It is.
Oh shoot! Did I mute you? Oh no.
I think I'm good.
You unmuted
Can
yourself.
You hear me?
Lovely. Yes. Okay.
So, hi everyone. My name is Veronica.
Can you maximize your PowerPoint?
I did. Is that okay?
Yeah, definitely.
Okay. So no email. You can't see an email.
No.
Okay. So I'll be talking about this paper. It will let me move. Let's see. It doesn't let. Oh, it does let me move. Multi-region exome sequencing of ovarian immature teratomas reveals 2N near-diploid genomes, paucity of somatic mutations, and extensive allelic imbalances shared across mature, immature, and disseminated components, which is kind of summarizing the paper. This is by this group mostly from San Francisco, from UCSF in California. And it was published in Modern Pathology pretty recently in January. So I won't be talking too much about the background because already Dr. Bonet and Dr. Rashid mentioned the 7 subtypes of the germ cell tumors. Just want to mention a few things about immature teratomas. They are the second most common malignant germ cell tumor of the ovary after the dysgerminomas. Most commonly in the first 3 decades of life and frequently present as bilateral ovarian disease. There is little known about the genetic underpinnings, which is part of why this paper is looking into it. And beyond dysgerminomas, actually few studies have performed genome level analysis of ovarian GCTs. So there's still a lot of unknown. Things like polysomy 12 and KIT mutations that have been found in ovarian mixed germ cell tumors that contain a dysgerminoma component, and also in testicular seminomas have not been found in pure teratomas. So what this paper is doing is multi-region whole exome sequencing to interrogate genetic cycosity, clonal relationship, DNA copy number, and mutational status in 52 distinct tumors from 10 patients that have mainly characterized as ovarian immature teratomas. Some had bilateral tumors and some had peritoneal dissemination. So for the methods, they resected the tumors in the 10 patients between 2002 to 2015 at UCSF Medical Center. A group of expert gynecologic pathologists have reviewed the diagnosis. And then they went on to whole exome sequencing. They actually took the tissue, so they punched from the paraffin block area that the areas are histological, they've seen the different specific components, so they isolated those from the 52 tumor separate regions. And they also used control, so they used mostly the uninvolved fallopian tube and then an endometrium, normal endometrium control for constitutional DNA. They also then they amplified genomic DNA and they sequenced using Illumina HiSeq. And then they, for candidate somatic mutations were identified using this platform MUTECT, and they also manually reviewed all the candidate mutations. And for allele-specific copy number analysis, they used this FACETS application. And then they classified the tumors in 1 to 5 categories based on this paper published in 90s by Surti et al., which I'll go a little bit more detail into those, based on cycosity status as centromeric and distal regions. And they compared, so for visualization of zygosity changes, they reported the absolute difference between theoretical heterozygosity, so an allele frequency of 0.5 of tumor versus normal tissue. So just quickly of this table from Surti, so the parthenogenesis, which comes from Greek, it's the development of germ cell tumors from unfertilized germ cells via different mechanisms of origin. I'll go a little bit more detail with their figure, but things like Nondisjunction error during meiosis 1 and 2, and they made those 5 categories that you see in the table here. So from the results, with categorizing the patient groups, there were 10 females between 8 and 29. 5 patients actually had debulking at initial surgery. 5 of them had bilateral ovarian tumors, some at the same time, some later, so 2 synchronous, 3 metachronous. The variation in tumor size from 4 to 30 cm. 7 patients actually had chemo because of the disseminated immature teratoma component. And at follow-up, patients actually are doing well. They're alive with stable disease from 2.4 to 15.3 years post original surgery. And for the histological features of the tumors, they are all primary ovarian immature teratomas with primitive neural tubules and a background of mature teratoma. 2 patients also had small foci of yolk sac tumor and embryonal carcinoma, and they were more categorized as a mixed germ cell tumor, even if the foci were small. And the disseminated disease was in peritoneum of 7 patients, and 6 out of those had gliomatosis peritonei. So just showing just some examples from their papers. You see here on the left, there's a left ovary with mature teratoma seeing epidermal differentiation. Also the left ovary with a neuroglial differentiation, so those both are mature components. On the bottom, the middle panel, you see immature teratoma with the neural tubules and the higher magnification here. And this is also in the disseminated part that you see the immature teratoma, and also the mature teratoma, you see some cartilage here. And the same, similar on the other side, except here that you have the peritoneum with the mature component is that neuroglial differentiation with the called gliomatosis peritonei. So for the results from the exome sequencing, from the 52 tumor samples from the 10 patients, they only found 31 unique high confidence somatic non-synonymous mutations, so mutations that would change the sequence of the protein. And the mutation, mean somatic mutation burden of this TMB was very, very low actually. They characterize it as one of the lowest of any human cancer type. They only found one somatic mutation present in all tumor regions from a single patient. This is PFKP, phosphofructokinase platelet. And it was present for all the components in one patient, but no genes were actually present in more than one patient. And no, none of those mutations known before from dysgerminomas or testicular germ cell tumors like KIT and KRAS or NRAS were found. Also, no isochrome 12P or polysomy 12P present as well. So overall, they had 2N diploid or near-diploid genomes with extensive loss of heterozygosity. And the identical patterns of this genomic loss of heterozygosity was, there was an identical pattern between the mature, immature, and the disseminated components showing a clonal origin. Interesting, the peritoneal disseminated components had identical pattern to one of the tumors, one of the ovarian tumors. But if they're bilateral tumors, the left and the right actually had different patterns of allelic imbalance, which showing that have an independent development. And then they concluded that diverse meiotic errors are likely to drive the development of this type of germ cell tumor. And I'll go back to that table that I presented initially, but 11 out of those 15 had either the mechanism 1 or 2 with the non-disjunction errors during meiosis 1 or 2. So here from some of those examples, those are the allele frequency and the loss of heterozygosity type of analysis. So if you look on the y-axis would be the delta AF, so the difference in allelic frequency, and on the x-axis are the chromosomes, so from here 1 to 22 and X. So I'm just magnifying one of them here. You can see what's on the top of the line of the y-axis is homozygote, and what's on the bottom here is heterozygote. And then the central line here, the interrupted line, is actually the level of the centromere. So here you can see from the two ovaries, the right and the left, there is actually quite a different pattern of allele frequency between the two tumors. And here, if we look at the right ovary versus left ovary, again, you see the patterns. If you look up, where you see the more homozygote type of allele frequency is different here than in the left ovary. However, the peritoneum is very similar to the right ovary. So this is the table I presented initially, and that's their figure. So most of the tumors in there analyzed by them or in this group 1 or 2, so the non-disjunction errors during meiosis. So if we look here at the table, we'll see they look at the level of the centromere versus the distal markers. So if we look here, this is the dotted line is the centromere versus the distal markers that they look at. And in type 1, you can see it should be heterozygote at the centromere. So we can see here it's at the bottom here, heterozygote, and plus minus homozygote at the distal markers. You can see here in the table as well. And if we look at the type 2, should be loss of heterozygosity at the centromere. So if we look here, you can see it's in this area of the homozygote area, and then plus minus at the level of the distal markers, which I think is a very nice figure. So from some of my points of view, I think this paper contributes to understanding of the clonal origin of the different components. So all the different components of the immature teratoma and mature and disseminated, they actually had a similar pattern of allelic frequency. And another interesting thing, I think, was the origin of gliomatosis peritonei, because they've been there are two theories now. One that develops from the tumor, from the original tumor of the dissemination of the teratoma, but also there is a spontaneous metaplasia of peritoneal stem cells to glial tissue. And some previous studies have shown no similarity with the original tumor, but they're small. However, the study actually shows pretty nice similarity between the original tumor and the disseminated components. I thought that was a very nice contribution to this paper. So some of the strengths, I think most of it is just this whole genome analysis, and they come with different type of characteristics from genetic zygosity, clonal relationship, DNA copy number, mutational status. And then they suggest those mechanisms, they contribute to our depth in understanding. Those mechanisms were suggested before, but they contribute to more understanding in that area. And for limitations, I can't really think of that many, but in general, the sample size could be increased, however, because there are only 10 patients. However, there are 52 tumor regions, so that's pretty good. Maybe if we can look at more than the 4 bilateral tumors, maybe discovering some connections between them and another type of analysis. This is already a pretty broad analysis, but I guess a whole genome sequencing could show more regions like intronic regions, or they usually have a little broader coverage. And one thing that I was thinking that maybe from the paraffin blocks, when they separate the samples, you can't really see exactly the tumors, so that might contribute to some contamination. Applications, I don't think necessarily for pathologists, but maybe, of course, it's for our understanding of how the tumors develop. But maybe for the clinicians, knowing that they're the same, or they have the same origin for the different components, that can help them with the treatment. So I think that's all I had.
Okay, that was a really nice presentation. You can stop sharing.
Stop sharing now.
Yep. And does anyone have any questions about this article? Oh, maybe someone's saying something in the chat. Let's see. Nope, not yet. Okay, the one question I had is I was kind of surprised they didn't talk about the prognostic differences between the different genetic findings. I kind of expected them to, because they did talk about the length of follow-up and status at last follow-up.
Right, they didn't really, maybe they didn't have enough cases to go into that.
Yeah, it would,
because they,
yeah. I just think that would be interesting, you know, because we know there's a difference, and that'll get in Dr. Zakka's article a little bit more about recurrence rates in mixed germ cell tumors versus pure sort of immature teratomas. We know there's a difference, so if there's maybe a different genetic underpinning in those two things, maybe this kind of data could, you know, lead to something in where they can do a sort of foundation medicine type panel on these young patients who get these tumors to see, you know, what the odds are for that kind of thing. But I thought that was a very technical paper, and you did a really good job. So thank you. Really appreciate it. And I agree. I really like their figure where they talk about the errors in meiosis 1. It was, it's a hard thing. It's a thing where if you don't think about it a lot, it's hard to sort of reacquaint yourself with it. But I thought that was a really nice article. So
I agree. It was very nice. Thank you.
Yeah. Does anyone know? It doesn't look like anyone has any questions. So Dr. Zakka, you're up.
So, hi everyone, I'm Fouad, also with Veronica on the same residency program. Really happy to be participating in this event today. The paper I'm presenting is frequent homozygosity in both mature and immature ovarian teratomas, a shared genetic basis of tumorigenesis. So this was published in Modern Pathology in 2017, and it's out of Connecticut, out of Yale University. So the study design here is to look at the origin of immature teratomas and mixed germ cell tumors. So these have not been that well elucidated, as well as much as we know about mature teratomas. So in this study, the authors are looking at the zygosity and trying to link that to the tumorigenesis of when looking at ovarian mature, immature teratomas and mixed germ cell tumors. And so the questions that they try to answer, the points they address, are that immature teratomas are posited to have similar origin as mature teratomas, and they try to look into that, and what kind of evidence they could further supply to this theory. So the way they went about this is that they had a total of 28 patients. They looked at 10 cases of mature teratomas, 11 cases of immature teratomas, and 7 cases of mixed germ cell tumors with immature teratoma component. They all came from a single institution. They were looked at by 3 pathologists. And what the pathologists did, they all tried to put in their input towards diagnosis and grading of the immature teratomas, the tumor components in the mixed germ cell tumors, identifying those, and the histologic composition of metastases whenever this was applicable, and as well as tumor staging. And as Dr. Pinay mentioned in the beginning, Veronica touched on as well, the grading scheme used for mature teratomas is at grade 1 if you have less than 1 low-power field with immature neuroepithelial tissue, and then grade 2 is 1 to 3, and grade 3 is more than 3 low-power fields in any slide. So they did tissue dissection and DNA extraction in the beginning, and they used formalin-fixed paraffin-embedded blocks for that. They got unstained slides where the area of interest were just scraped off with a scalpel. The DNA was extracted by hydrothermal pressure methods, which is simultaneous deparaffinization and lysis of formalin-fixed paraffin-embedded tissue. And then what they did with that was short-term short tandem repeat genotype analysis. So they used multiplex PCR at 15 short tandem repeat loci, and it was followed by capillary electrophoresis. And then in terms of data collection and analysis, they used gene mapper software. And then the way they kind of analyzed the tissue and started interpreting it is that they looked at the loci of interest, and they determined that genetic loci are informative if their 2 distinct alleles are residing within the given locus. So, and then they further went to say that if it's informative and it's 1 allele, it's homozygous. If there are 2 alleles, it's heterozygous. And if there was homozygosity at all the informative loci for the tumor, it was complete homozygosity. If it was more than 30%, but not 100% homozygosity, it was called partial homozygosity. And then if homozygosity was less than 30%, they just assigned it as heterozygous. So for the results, they just elucidating the characteristics of the tumors that we have. So looking at the immature teratomas, the mean age for those was 25. For the mature teratomas, the mean age was 35, and the mixed germ cell tumors, the mean age is 24. And then histologically, all the immature teratomas, so we're looking right here, were, in terms of grading, were either grade 2 or 3, so it's considered high grade. All the mixed germ cell tumors had a grade 3 immature teratoma component and either a yolk sac or embryonal component. And then what kind of is also interesting to look at is the follow-up. So the immature teratomas had no recurrence when follow-up was available. You can see that these 2 cases here did not have any follow-up. The mixed germ cell tumors had recurrence, and the mature teratomas, they just didn't look into that, or they did not have follow-up. So moving on, this is figure 1 that we're looking at, and this is just an example, first of all, of how they went about things. And this is an immature teratoma where you can easily see the primitive immature neuroepithelial component. So this, obviously, was easy to classify as high grade, and this is just a high power of what the tubules looked like. And so when they did their zygosity studies on this, they compared the tumor to normal tissue, and these up here are the informative loci that you're looking at. So the tumor, you can see, has 1 spike, the normal tissue has 2 spikes at loci, so this is a pure homozygous case when you looked at the zygosity for the tumor. And on the other hand, some other immature teratomas were heterozygous. In this particular case that we looked at here, they're showing on the left that it had mature elements. So you can see these, you can see the sebaceous differentiation with duct formation, keratin and lumen. And then on the right, you can see the immature neuroectodermal tissue. And when they ran zygosity studies on these cases, this is just one example, comparing it to the normal, the tumor at the informative loci was just heterozygous for that. So the genotyping result here, they summarize this in a later table a little bit nicer, is that you see when you look at the immature teratoma, you see that the homozygosity is quite high, whether it's partial homozygosity or complete homozygosity. However, when you look at the mixed germ cell tumors, they have more cases of heterozygosity, partial homozygosity, and no complete homozygosity. And when you compare to the mature teratoma, you had a few cases that were heterozygous, but the majority were homozygous, either partial or complete. They also had one case of recurrence of mixed germ cell tumor. And it was just interesting the way that they looked at this. This is the original, the primary, and this last figure here is the recurrence. So this had a yolk sac component in it, and it stained positive for alpha-fetoprotein, and also had immature teratoma component as well. And these are the primitive tubules that we were seeing earlier. However, when it recurred, it only had mature differentiation to it. So you're looking at some respiratory epithelium, some mature adipose tissue. So when they ran the zygosity studies on that particular case, this is normal tissue, this is the teratoma at diagnosis, the recurrence had the same zygosity profile as the original, the mixed germ cell tumor at presentation, even though it had mature elements. So when we summarize what they found in terms of zygosity, the mature teratomas, I think this is the most informative over here, the percentage with homozygosity. You can see 63% had homozygosity. Immature teratomas, 86% had some sort of homozygosity. As for mixed germ cell tumors, it's kind of different, and they had 33% here. So further discussion, it's always been thought historically that the most mature teratomas are thought to occur from failure from meiosis II and minority from failure of meiosis I. And the authors are saying that they were able to show in their study through zygosity because they correlated the failure from meiosis II with homozygosity, which was 63% of their cases, and heterozygosity with the failure of meiosis I, which was in 37% of their cases. And they also showed that there's a similar frequency of homozygosity between mature and immature teratoma, and they're saying that this can imply a common pathogenesis. And they further kind of strengthen their argument by saying that none of the pure immature teratomas recurred. And so they're likening their behavior to mature teratomas. And the difference in homozygosity between mixed germ cell tumors and immature teratomas, even though it wasn't clinically significant in their study, it suggests a different pathogenesis. Remember, said that in that table back there, here, that immature teratomas had a homozygosity of 86%, and while the mixed germ cell tumors had 33%. So they're saying that this might suggest a different pathogenesis. And they also showed that mixed germ cell tumors recurred more commonly, 4 out of the 5 cases that they could follow up, and this was clinically significant in their study. And the pure immature teratomas did not show recurrence. And they're saying that this can have implications on survival rate. And what makes us maybe as pathologists want to think about is the importance of thoroughly examining a presumed immature teratoma for other parts. So could it have a yolk sac component? Could it have anything else in there? And so on our end, does that mean we should, aggressively pursue that further with looking deeper into the tissue, or trying to preemptively get any staining just for screening purposes? So we want to talk about the strengths and areas of improvement for the studies. What I felt here, that the strength of the studies also somewhat lied in the simplicity, that there wasn't much room for error and subjective assessment. So either, the loci are showing homozygosity or heterozygosity, and there's not much in between. And also I felt in terms of strengths that these are worthwhile clinical implications, that maybe one could say, could we have a more relaxed approach to pure immature teratoma once we of course, ascertain that it's a pure immature teratoma, that these are not going to behave as badly as a mixed germ cell tumor. And also in terms of strength of the study, maybe more on the academic side, it furthers our understanding of the origin of these tumors, where they're coming from and where they're going in terms of behavior. Areas for improvement, obviously a larger population is required for this. I don't think we can really ascertain much about recurrence from just looking at 4 of 5 cases. And in that sense, maybe what Dr. Benet was saying earlier, maybe some more robust genetic studies are warranted to try and come up with that. So for future applications, or how would we really apply this in our practice as pathologists, I thought maybe at this point it might be limited. The reason for that is I feel that the behavior of these neoplasms is kind of well known by now, and it's well known that if you have an immature teratoma, you need to sample the tissue extensively to make sure there are no other components there which will ultimately affect prognosis. And I feel right now that the strength of the study, it's more academic, as I was saying, in highlighting where the origin of these entities, and just like really validating something that is already known at this point. So I know I have to do a little follow-up quiz. Or is that later?
Yeah, I can post that on the web later. I don't want to give away the punchline to everybody. Thank you so much. So, that was a really good presentation, Dr. Zakka. I appreciate that. And I think I have somebody raised their hand. Oh, is that you? Did you raise your hand?
Yes, that's me, yeah.
Okay, go ahead. We can't see your whole face. I can only see your eyeballs.
All right, okay. Yeah. Sorry.
Okay.
So are you able to hear me clearly, though?
Yeah,
Yes.
we can hear you. Thank you.
Okay, right. Yeah, just one observation and one question as well. I don't know if that's your impression and the impression of others as well. So many times we do see that in immature teratomas, the ones which are higher grade, the grade 2s or 3s, often have a raised alpha-fetoprotein, although in the sampled areas, we haven't necessarily seen yolk sac tumor. So I'm just thinking that based on what we have seen from this study, does this mean that we have actually missed the yolk sac tumor, or is there any other mechanism by which the alpha-fetoprotein is raised?
Do you mean the alpha-fetoprotein in the patient's blood?
With immature teratoma, with a high-grade immature teratoma, yeah.
But in the blood, you're not talking about immunostaining. You're talking about elevated AFP.
In the blood, yes, sorry, yes.
In so much as I understand it, I think the AFP elevation can be minor in immature teratomas, and I don't know that it necessarily indicates that there is a yolk sac component. My experience with immature teratomas is that I find them kind of terrifying, because you know the implications of missing, like you're saying, a yolk sac component, right? Like, you know, for the patient, that is a real line in the sand for them. And I find thorough sampling is helpful, but I also think that yolk sac tumor is something that when you look into it, the more you know, the more scared you are, because there are about 25 patterns of yolk sac tumor, right? And it can really kind of hide, especially if you have a lot of neuroepithelium and other immature elements, not just neural epithelium. So I find that careful sampling and also comparison and consultation with other pathologists. And I think these are cases where it is worth it to send them to folks who see them a lot, right? Like if you have a pediatric pathologist, if you know a GU pathologist, those are other good people to collaborate with, because they do see germ cell tumors as well. Obviously not in, genotypic females, but I find that those are all good things. And the other thing I wanted to mention, Dr. Zakka, you pointed out the emphasis that we need to place, especially in these tumors, on sampling. And I found that when I was in my fellowship in a high consultative service, the kinds of consults we got were not often, is this an immature teratoma, when it was a grade 3, right? Because those you can just recognize at 1x practically. It was the ones where you have a mature teratoma with some immature elements, and like, is it enough? And that breakpoint between 1 and 2. And in those situations, if you are going to consult somebody, make sure you've gone back to the bucket yourself, right? Because once you leave academics, nobody's going to make you do that. You have to do it to yourself. And you can pretend you're your own resident or PA, but those are important. And then as a pathologist, obviously, Dr. Dasgupta, I hope I pronounced your name right, emphasized finding those yolk sac components, finding those embryonal components, because as you noted, those are the patients that recur, right? Those are the patients that we think are doing worse. Although I did find it interesting that it was statistically significant, the recurrence, because we're talking about 5 cases, right?
Exactly.
And so I think you have to be kind of cautious when you have numbers that small. And the original paper that I cited before, and granted this was during a time when they were probably doing different therapies for these patients, but the grade 3 patients all died of disease. So it's not trivial to have an immature teratoma, although I'm sure it's better than having that mixed with a yolk sac tumor. So there are collaborative studies going on around the world with things like endocervical adenocarcinoma right now. So perhaps the next thing we need to do for rare tumors like this is get together a bunch of people. I don't know if Jonathan is still on, but we can get some cases from your part of the world, compare them to everyone else's, and do follow-up and see what happens there. So did any...
Just as a follow-up for Dr. Dasgupta, but for us, and at my level as a trainee, this is but maybe not something I'm aware of, but if the AFP is high in the serum, would that prompt the pathologist to sample more or be more aggressive than they usually would be? Or has there been studies correlating that, what the chances are of finding actually other components if the serum level is high?
I mean, I don't know, but personally, the few cases in which I've seen the serum AFP is slightly raised, not to really that great extent, and I've sampled extensively. I've never actually found any coexistent yolk sac tumor, and that is exactly where I was thinking to put this study into perspective. So in those cases, does this sort of elevate studies can reassure me that really I haven't missed anything? That is a reassurance I was trying to see, that is that true or not? Because as you have pointed out, and we all know that there's a difference in the behavior between just an immature teratoma, even if it is very high grade, from a real mixed germ cell tumor, when I could have missed a small area of yolk sac tumor.
Yeah, that's a good thing to look into, and I can look into it. But at least from my reading and what I understand is that in germ cell tumors in general, you can get minor elevations of those serum markers. It doesn't necessarily mean that tumor is there, but of course it makes you wonder, how in the world is it getting there? Exactly. But I think
that is actually very common in testis. I think I've found that more commonly in testicular seminomas, pure seminomas with slightly raised AFP.
And then
but in those cases, I've also seen some scarring, so I don't know whether those are areas of regressed some other components or not. But
Right. And where are you practicing pathology?
I'm in UK, University Hospital of North Tees.
Oh, okay. That's good to know. And it sounds like you do general surgical pathology. So
that's correct, yes.
You're a brave person. That's great.
I love to do general surgical pathology.
Me too, actually. I miss it. So does anyone else have questions for any of our presenters or in general? Anybody else want to say hello? Show your face.
Hello.
No? Who's saying hi? Oh, it's Dr. Hassan. How are you?
How are you?
Good. Thank you for joining us. Yeah.
It was very nice today. Nice presentations.
I agree. I think it's getting better with time. I'm getting less awkward. I have more of an idea what's going on. So just keeps getting better and better. So thank you, Dr. Rashid, Dr. Zakka, Dr. Ullici. We appreciate it. And let me just make sure we don't have any other questions. So I'm going to end the meeting, but I will see everyone next month, hopefully. Thank you.
Thank you very much.
This was great. Thank you.
Thank you very much indeed. It's a pleasure.
Yeah, thank you.
Thank you.